life after death. But you can't breathe if you lose your breath. I can't breathe. So thank you once again for indulging me. With that, I thought that would create a nice nexus between Dr. Lawrence Brown's presentation, facilitated by Andrea in such a beautiful way, and our next presentation. We are going to now introduce via video Councilman Will Jawando from Montgomery County, and the panelist joining him will be Dr. Nilesh K, known as Dr. K, from the Anne Arundel County Health, who's the Anne Arundel County Health Officer, Dr. Kamara Jones, and the moderator will be Dr. John Hudgens, who is an associate professor of sociology and human services, and he will serve as our moderator and contributor to this workshop. So without further ado, let's get started.
Thank you, Keith, for that introduction. I'm Councilmember Will Jawando. It's good to be with you all virtually. I'm sorry I couldn't be there in person, but this is a very, very important conversation that I just couldn't miss. I'm really happy that we're focusing on Black health and wellness. We are a state where over 30% of our population here in Maryland are African American. We are south of the Mason-Dixon line. We have a history of racial discrimination and a legacy of slavery. I often remind my children and folks I work with that Maryland is the state that Harriet Tubman and Frederick Douglass ran away from. We had just as many people fighting in the Civil War as we did on the Union side as we did on the Confederacy. And so we have work to do, as does the rest of America, in making sure that all of our population has what it needs to thrive. In this discussion on racism and its impacts on health, both public health and individual health, are immense. We saw that in COVID, and I was right here at this desk, in this office, in our building, in the County Council here in Rockville, making decisions about how we administered the vaccine, which communities were hit the hardest. And we saw that our community, people of color, Black, Latino residents, were disproportionately impacted and also had the least access and availability and knowledge about the vaccine. It's one of the reasons that in June of 2020, I introduced a resolution co-sponsored by all of my colleagues and supported by all my colleagues, declaring racism a public health crisis here in Montgomery County. And why did we do this? Because we know race is a social construct, but it has real life impacts. When you look at the African American community, we die in many ways. We die in childbirth. Our women at the highest rates, despite their level of income or level of education. We know doctors are less likely to believe us when we're sick and then treat us in different ways. We die on our streets and our roadways because our communities have been disinvested in and get hit by cars, trucks, and buses more than other populations because we don't have sidewalks and proper transportation and public transportation that's reliable. We die from police violence at higher rates, the highest rates of any people in America, because we have inequitable systems of justice. And yes, when COVID was hitting us hard, we were dying 10 years younger than our white counterparts. A white person who contracted COVID at 65 had a higher chance of survival than a Black person who contracted COVID at 55. It's one of the reasons I pushed Governor Hogan to allow us to give a vaccine sooner to African American and Latino residents who had worse health outcomes. Unfortunately, he denied that action. But our policies must recognize that racism is a public health crisis. You look at our housing crisis, our educational crisis. So much of it is determined by zip code and race and ethnicity. And so our policies must reflect that. So when we introduce this resolution, like the American Psychological Association, like a growing body of research and entities around the country who have declared racism a public health crisis, the solution has to match up with the problem. So what are we doing here in Montgomery County that I think we need to do statewide? We need to, one, acknowledge the history and legacy of racism in all of our public policies, in housing and education and healthcare, in policing, in transportation, in our environmental policy. Because in each of those areas, we see racism both systemically and individually, leading to shorter life and a lower quality of life for our Black residents. And we must be honest about that. You can't fix the problem. If you go to the doctor, they can't fix it unless they properly diagnose it. And racism is embedded in all those systems and structures. That's step one, acknowledging it. That's why I've pushed the state legislature and the governor to declare racism a public health crisis here in the state of Maryland. That's one step we need to take. Two, we need to make sure all of our staff, government, contractors that work with us, that interact with our public, know the history of racism and segregation and discrimination in our communities and how that impacts delivery of service and the health and wellness of our communities. If we don't know the history, we can't appropriately adjust for those policies. If you're a doctor, for example, you need to understand the history of the African American community and the healthcare system and how we've been discriminated against over years and centuries, so that you can be aware and more attuned to the needs of your African American patients as well as all your patients. Third, we need to have policies that specifically address race and race discrimination and disparities across all of our issues. It's why we passed a racial equity and social justice law in this county. So every bill and policy we consider goes through that analysis of what's the history of racial discrimination on this issue, what could be some potential ways to mitigate and improve and reduce those disparities. You have to be intentional every time, every policy, every issue. And that has to be systemically baked into how we do our work. And finally, we need to make sure our staff is trained. Those of us who are fortunate enough to hold public office or serve in the public realm, we need to go through racial equity and social justice training ourselves. So one of the actions in my resolution mandated that all council staff be trained in racial equity and social justice and understand the history of these disparities. And the last thing we've done is we've, in the process of setting up a commission on health disparities that will make recommendations very specifically in the health arena of how we can improve the health and wellness of our African American community, but all of our diverse populations. I think these are some of the steps that we need to take here in Montgomery County, but in the state of Maryland to address these issues. I really look forward to the conversation that's going to happen on the panel afterwards with Dr. Jones and Dr. Hudgens and Dr. Nalish. And I really want to thank the Black Mental Health Alliance for putting on this program. The work that you're doing in our community, in our state, in our region is so important. And I'm here to support it, and all of us are here to support you. So thank you for having me, and thank you for this important discussion today.
All right, there we go. So thank you, Councilman Jawando. I believe now we're going to move into the discussion.
Okay, I guess I'm up. I'm John Hudgens. I'm going to serve as the moderator for the upcoming plenary, and I'm only going to make a few brief remarks as I want to hear from our presenters, and I'm sure they have worked to prepare what it is they're going to say. Just briefly, it looks like about 33 years ago, Louis Sullivan, who was a secretary of the Department of Health and Human Services in the Bush administration, publicly said that we need to start looking at racism as a public health crisis, allowing for the fact that the existence of racism is deadly in terms of people actually dying, but certainly in terms of people having adverse qualities of life. We've known historically that Black people do not live as long as white people. We saw it, as many people have said already, dramatically illustrated during the COVID crisis. And just about every health indicator you look at, by and large, Black people, and to a lesser degree, Native American people, I think Hispanic people kind of fall in the middle, but basically suffer adverse consequences, health consequences relative to whites. What I hope we can do, we're talking about as a topic, now what? And I think there are two ways that I want us to look at. One is obviously what we've been talking about for a long time, and that's the treatment of racism. We have to do something about racism. We have to do something about white supremacy. We have to change the narrative as best we can. But at the same time, we have to be cognizant of and treat the effects, particularly the health effects. What do we do in our communities? And the councilman mentioned a few minutes ago with his resolution, things that we can actually do to impact the health of each other. And I just want to close by saying that has historically been the challenge and the effort in the African-American community. We have done our best to patch up each other, whether it's home remedies or making sure we got people into medical school and out of medical school, lobbying for doctors in hospitals, lobbying for doctors and nurses, and Black people included in the healthcare professions. A lot of things we have done and tried to do to deal with the effects of racism at the same time that we're fighting to try to get rid of it on a broader scale. So I'm going to stop there, and hopefully we'll have a good chance, a good opportunity for discussion. I think our panelists are probably prepared to do 10 to 15 minutes of their presentations. So we're going to go ahead and move ahead. I don't know who's going to start. I guess the way it's listed here would be Dr. K. Nalish K, and I'm sorry I can't pronounce your last name, but maybe one day I will figure that out. So if you want to go ahead and start, that'll be wonderful.
Actually, Dr. Jones is going to go first, so I will turn it over to her.
Excuse me.
Thank you. And so I'm delighted to be here. I haven't been here the whole day, but I was so delighted to pick up the last part of Dr. Brown's talk, and amazing. So now we're turning a little bit more specifically to health. I'm going to share some slides and spend just a little bit of time talking about confronting racism denial. Like, that's like a huge black hole in our national landscape. We all know racism exists, but when you try to move counties to action or states to action. So, Senator Nathan Pulliam, thank you for getting that commission going. Finally, Dr. Kalyana Raman, yes, Dr. Kalyana Raman, and also Commissioner Jawando, thank you for moving to action, but people are almost like deer in the headlights. So I wanted to start out by saying these declarations that racism is a public health crisis is a way of putting the stake in the sand by city councils, county commissions, and the like, saying that we acknowledge that racism exists. Just to give you a little bit of additional history on that, when I was president of the American Public Health Association 6 years ago in 2016, I actually launched our association and other, American Medical Association committees, the state public health associations, anyone who would join us on a national campaign against racism with 3 tasks. The first being to name racism, because you must name a problem in order to get started on the solution. The second is to ask the question, how is racism operating here? Not even is racism operating here, because we know racism is foundational in our nation's history and continues to have, devastatingly profoundly negative impacts on the health and well-being of our nation. So the question, how is racism operating here? Looking at structures, which are actually the who, what, when, and where of decision-making, who's at the table, who's not. Policies, the written how of decision-making. Practices and norms, the unwritten how of decision-making. Values, the why. Looking at structures, policies, practices, norms, and values, which are actually the elements of decision-making, to do some landscaping, identifying levers for intervention, targets for action. And then once you've done that and you say, okay, we must act, and so we're going to start acting here, together we need to organize and strategize to act. That national campaign against racism was in 2016. Now I'd like to share with you how ideas spread, kind of like how germs spread. In May of 2018, Lillian Payne at the Wisconsin Public Health Association for the association wrote the first declaration that racism is a public health crisis. And then a year after that, in May of 2019, the county commissioner in Milwaukee, Wisconsin, was the first jurisdiction to pass that. Now I'm going to have this map progressing month by month, where you see it went to Illinois, to Missouri, and then you see Maryland was the fourth, Anne Arundel County. Now we're getting into the recognition of COVID. Here we are in May of 2020, but what else happened in May of 2020? On May 25th, Mr. George Floyd was brutally murdered and very publicly lynched. And then you see the number of states that have at least one city council, county commission making a declaration that racism is a public health crisis. They're piling on and on and on. I'm going to pause again here in April of 2021, which is when the Centers for Disease Control and Prevention finally added their voice and said that racism is a severe threat to the public's health. And then June of last year, Alaska was the last. Now you're going to see months piling up, but these 9 states that haven't had anybody in those states make a jurisdiction, they are staying pat. The last time that I animated my map was in June of 2022, but those 9 states, Idaho, Montana, Wyoming, North Dakota, South Dakota, New Mexico, Louisiana, South Carolina, and New Hampshire have no cities, counties, nobody in the state has made a jurisdiction. These are the states as of mid-June, the 239 jurisdictions in 41 states and the District of Columbia that have made declarations. In Maryland, we have 4. So the first was Anne Arundel County, and then Montgomery County, then Prince George's County, and then Frederick, Maryland, have made those declarations. People putting in stake in the sand. And as Councilman Jawando said, some counties and cities, they just said racism is a public health crisis, and they stopped there. That's important. You got to name racism, right? But others said, and therefore we're making these investments. And therefore we're inviting this kind of community voice. And therefore we're going to have the kinds of checklists that Councilman Jawando described. Every time you do a policy, you're going to make sure that it meets these requirements. The first part though, the naming racism, 239 jurisdictions across 41 states and the District of Columbia have done that. There are 4 key messages when we name racism. The first is that racism exists. And I say that because racism denial, as I said, is so staunchly held in our society. The second is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth, yes, we can act to dismantle racism. The rest of the time that I have with you today is not just to show the map of how these ideas spread about this particular racism declaration idea. And you know, there in Maryland, you got a lot more counties and you got cities and you have the whole state. I mean, you could actually, part of the action out of this might be actually to go to your county folks or to try to push something at the state level of a state declaration that racism is a public health crisis. I'm not there yet. We're going to have discussion. But I do want to share with you one of the images, one of my allegories that I share to equip people to challenge the racism denial that surrounds us. This allegory that I call Dual Reality, a Restaurant Saga, is to help some people understand that racism exists, but help all of us communicate to others that racism exists. So when you listen to this allegory, I actually want you to listen in a way that you can share it with some other folks later this evening. The story is based on something that happened in my own real life. I'm a physician, I'm an epidemiologist, past president of the American Public Health Association. My work is on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation and the world. As a first-year medical student, where I was very diligent, very studious, so now I want you to step in my shoes as a first-year medical student. I had awakened on a Saturday and I hit the books early like I always did. And I was studying long and hard. It was already mid-afternoon. Some friends came over. Did they distract me from my studies? Oh no, we all got to studying long and hard because they were medical students too. And by this time it was getting late. And we were getting hungry and I had no food in the apartment, which was so typical of me that my friends actually understood, but they were like, okay. never mind, Kamara, we got that. You have no food in the apartment, but we're hungry. Let's go into town and find something to eat. So we do. So we walk into town and we find a restaurant, and we walk in and we sit down, and the menus are presented, and we order our food, and the food is served. Here we are eating. And so you can be like, Dr. Jones, really? That's some revelation about racism exists? Well, and I know for people in my generation, it's not the story you thought I was going to tell about racism exists in a restaurant because the food was served. But hold on. As I sat there with my friends eating, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now I perhaps have intrigued you and you're wondering, well, Dr. Jones, what did the sign say? Well, what did the sign say? The sign said open. So now maybe I've lost most of you. How is a sign that says open a startling revelation about racism? Well, hold on, let me recap. Here I am sitting inside a restaurant with my friends eating. I look across the room, I see a sign that says open, thinking no more about it. I assume other hungry people can walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that indeed the restaurant was closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of the sign, would not be able to come and sit down, order their food and eat. And that's when I recognized that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. We know this, we live this, but stay with me in the story because I want you to be able to tell this story on. And for those who are sitting inside the restaurant, at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. So for example, it's difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. It's actually difficult for all Americans to recognize our American privilege in the global context. Although we are living it so large, we did as for these last 2 years with how much of the global supply of COVID-19 vaccine we had sequestered in this nation. But those on the outside, they are very well aware there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say to them, you know, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, then those people inside the restaurant, they could even, talk to the restaurant owner because the restaurant owner is actually inside with them, and they could say restaurant owner if they care about those on the other side of the sign. There are hungry people outside. Why don't you open the door and let them come in? You'll make more money. And the conversations we could have. Or maybe what those people would do is pass some food through the window or really try to tear down the sign or break through the door. But at least what they won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because they'll understand something about the two-sided nature of that sign that proclaims open to them. So when I am speaking to any audience, but especially audiences where some of the people don't even recognize that racism exists, this is the story I tell for them to understand and for all of us to equip us to communicate as a communication tool that yes, racism exists. It is creating a two-sided or multi-sided sign. It is structuring a dual reality. And actually, I've started 3-hour conversations in Flint, Michigan once, and I forgot some of the other places with the following question: how could people who were born inside the restaurant know something about the two-sided nature of the sign? And each time it was a 3-hour conversation because there are many ways to know. I am actually heartened a little bit that more people who just 2.5 years ago might have been sitting inside the restaurant at the table of opportunity eating and saying, well, what are those people outside saying? Black lives matter? Don't they know all lives matter? More of those people are actually affirming, yes, Black lives matter. more of those people are passing resolutions, declarations that racism is a public health crisis. More of those people, are actually saying the word racism, putting together the phrases structural racism, systemic racism. This is encouraging, but here is my warning. If any of us just say a thing, right? 6 months from now, we may forget why we said that thing, because racism denial is so staunchly held by so many in our society, and it's so seductive that we ourselves might fall back into what I describe as the sleepiness, the somnolence of racism denial. So we must go beyond naming racism to action, which means we need to tear down that sign. And of course, racism is not just a sign. It's the sign, it's the door, it's the lock. There's a whole system going on. We need to dismantle the lock, take the door off the hinges, because once we start acting, we won't forget why we're acting. So I share that as a little image that whenever you come across people, even some of us don't want to say the word racism. We'd be talking all about diversity, equity, inclusion, belonging, structural competence, cultural competence, cultural humility, diverse, disparities, disproportionality. We talk about all that stuff and never say the word racism. And if we are doing all that work, but we never say the word racism in our national context of widespread and deeply held racism denial, we're complicit with that denial. I'm just going to speed through my definition of racism, come back to that image, and then pass the mic over to Dr. K. If we are going to define racism, my definition starts with the acknowledgement that racism is a system. So racism is not an individual character flaw, personal moral failing, psychiatric illness, even though, it can show up in all those ways. But in its essence, it's a system of power, and a system of doing what? A system of doing two things, of structuring opportunity and assigning value. And on what basis is the opportunity structured? On what basis is the value assigned? Based on so-called race, which is the social interpretation of how one looks in our race-conscious society. And what are the impacts of racism? Well, when we think about racism, we usually acknowledge that racism is unfairly disadvantaging some individuals and communities. But it shouldn't take any of us long to recognize that every unfair disadvantage has its reciprocal unfair advantage. So racism is also unfairly advantaging other individuals and communities. And clearly we had examples of that with Dr. Brown's work, with probably all the work that you guys have been sharing and discussing this whole day. But even as we recognize that duality, racism is having a third impact, which is under-recognized by many of us, and that is that racism is sapping the strength of the whole society through the waste of human resources. So when we don't vigorously invest in the full, excellent public education of all of our kids, when we are complacent with the wholesale warehousing disproportionately of so many Black and brown men in our prison system, as if that didn't separate us from human potential. These are just some of, I could give you 10 minutes of examples of how racism is sapping the strength of the whole society. I won't stay there. I'm going to go back to this image now of the dual reality and say, I am aware in all of this work that we're doing, that there are many people in our communities, in our workplaces in this country who value comfort. And there are many people in our communities, in our workplaces in this country who value social justice. And in the current status quo, valuing comfort and valuing social justice are at polar opposite ends of a value system. And in fact, those who value comfort are very much like those who were born inside the restaurant, sitting at the table of opportunity eating. They value comfort because they are benefited by the status quo. They're comfortable in the status quo. They don't even wonder why isn't anybody else coming in, right? They may not even notice that nobody else is coming inside that restaurant because they're so involved in their food and their conversation is so self-satisfied. They certainly don't want to examine the sign to see if it's really two-sided. They might have heard there was something about a two-sided sign, but they're passing laws all across this country that you cannot examine that sign to see if it really says closed on the other side, because it might make their children uncomfortable. They don't care to know what the outsiders are saying. They aren't even trying to say, what are those people saying? They don't even believe that an outsider could add anything to their conversation, right? They don't They think, well, if they have to be politically correct, maybe they'll hire somebody from the outside and put them prominently near the window so other people on the outside can see them there. But they really don't think that that person is going to bring genius and creativity and a different lived experience to improve things for all. They don't even wonder how the food they're eating got to them. They don't recognize that those people who can't come in and sit down in the restaurant are the ones who are growing the food, transporting the food, bringing it into the kitchen, cooking the food, serving the food, and still can't eat it. And they certainly do not want to budge from their seats at the table. They very jealously guard their comfort and their privilege. Now, those who value social justice because they know two things. First of all, they know there's a two-sided sign going on. Many of us, because we were born on the other side where the sign says closed, and yet we can look through the window and see people inside eating. They also know that the operation of this two-sided sign saps the strength of the whole society through the waste of human resources. Now, I am not saying that the circumstances of our birth completely determine our value system. And I acknowledge that people who were born inside the restaurant may wonder why nobody else is coming in. Maybe they say, what are those people saying? And they can make their way out. It's hard for them. But they can make their way out, live, go on the other side of town, live in somebody else's experience. That's important. I also acknowledge that some of us who were born outside can make our way in, but the stories we have to tell, and sometimes the promises we have to make to never mention that there's a two-sided sign going on. It's hard to get inside. And then when we do, as I say, sometimes we are positioned near the window so others on the outside can see us. Sometimes we use that position to also be near the door, and we put our foot in the door to keep the door open, make it easier for more people to get in. But sometimes we are the very gatekeepers to make it more difficult for people on the outside to get in. I am not saying who, what, anything, but except for this. What we must do on the value sides of things. So we have to deal with structures, policies, practices, norms, and values. But on the value side, we need to move our communities, our workplaces, this nation, so that move more people from valuing comfort to valuing social justice, even as we recognize that valuing social justice in the current status quo will not always, or maybe even ever, be comfortable. But we need to recognize that for all of us, the edge of our comfort is our growing edge. So what can we do today? We need to look for evidence of two-sided signs. Is there something differential going on by race, by gender, by zip code, by urban, rural, by religion, by any of the ways? And we have to look not just at outcomes like health outcomes, but also at opportunity structures, the quality of the soil. We need to burst through our bubbles of experience and experience our common humanity on the other side of town. We need to be interested in the stories of others, believe the stories of others, join in the stories of others. We need to develop a sensitivity to the absence of who's not at the table, what's not on the agenda, what policies are not in place that if put in place could bring more social justice. And especially we need to reveal inaction, lack of action in the face of need, because that is how structural racism very often manifests these days. But I am not saying that all the power is inside the restaurant, not at all. And those of us on the outside need to recognize our power. We need to recognize that action is power, and especially that collective action is power, because collective action informs us, inspires us, propels us, protects us. So we need to build a critical mass and go into collective action. So now with that kind of framing overall of the importance of 4 key messages about racism, the first being to name racism. And so we have to say racism exists, racism is a system, racism saps the strength of the whole society, and we can act to dismantle racism. I turn the table over to Dr. Hold on, I know how to say your name, and I'm going to say it so other people know how to say it too. Kalyanaraman. So Dr. Kalyanaraman, thank you very much.
Thank you, Dr. Jones. I'm going to share my screen, so give me a moment. So I appreciate the opportunity to speak with you today. I want to thank Dr. Jones. I have been reading your work for many years, so it's it's a really neat opportunity to present with you as well. So as noted earlier, I'm Nilesh Kalyanaraman. I'm the health officer in Anne Arundel County, and I want to talk about what it looks like to address racism as a public health issue. I always like to start with this slide. It gives us, I think, a really good framework of why we care about health and why we care about public health. So Anne Arundel County has a population of about 590,000 people. It's the fourth largest jurisdiction in Maryland. And critically, I always kind of go right to what's the life expectancy. And when we look at that by zip codes in Anne Arundel County, we see that the highest life expectancy is 85.9 years, and it's in Arnold, and I've circled that in red. And then the lowest life expectancy is 70.9 years in Brooklyn, which is right at the northernmost edge of the county. And you can see that there's obviously a spectrum. But I think the most important thing to take from this is that we can tell what the average life expectancy is based on where you live, right? And that's a 15-year difference between the highest and lowest life expectancy. And if you're not familiar with the geography of Anne Arundel County, it is a 15-mile drive down Route 2 from Brooklyn to Arnold, and you literally get 1 year for every mile you drive. So when we look at the race and ethnicity demographics in the county, we see that Anne Arundel is about 67% white, 19% Black, about 8.5%, 9% Hispanic, 5% Asian, and then 0.3% Indigenous. And I've included the stats for Maryland and the United States just to give you a little bit of a comparison. So what determines that life expectancy? What determines how long people are going to live? So we have been of late, and I'll talk about this a bit more, looking a lot at maps to try to understand the geography of what's happening. And I've included three different areas here, three different determinants here. The first one, the one that's the orange-brown color, just identifies the percent of population identifying as racial ethnic minority. And the darker it is, the higher the percentage of minority population in that area. The second one, the middle one that's in the green tones, identifies people with the percentage in that area with less than a high school education, so lower educational attainment. The darker areas are the ones with the lower overall educational attainment. And then the last one is in the purplish tones. It's the median household income in that area. And the darker the color, the lower the median household income in that area. And when you look at this, and there's a reason I put them side by side, as your eyes scan, there's nothing, there's nothing particularly inherent to being a racial or ethnic minority that should then show up in these next two maps, right? But that's why we're talking about racism, is because when you look at these maps, they're very similar. You can overlay them on each other, right? And to make that really more explicit, I'm going to put the one that identifies racial ethnic minority percentages next to our life expectancy. And there's a high area of overlap in terms of the higher the racial ethnic minority percentage in a zip code, the lower the average life expectancy. And so when we look at this and when we break this down, what we see is that race and geography really determine access to income, education, a whole host of other factors. I only included these two because that's what I was showing you. And then those are the things that pour out into life expectancy. There's really nothing inherent to, when we analyze the data, there's nothing inherent to the race or the geography that suggests that your life expectancy should be lower. It's how they impact your access to these factors. And so I couldn't help but take the opportunity to note that on the American Public Health Association webpage that addresses racism as a public health issue, this is the quote that starts the page. And so when I noted that it's really an honor to be on this panel with Dr. Jones, I don't have to discuss racism because she's already done that. And I would love to say that one day I will do it as well as she does. But I do think it's important to understand what it looks like at the local level, what it means for us to do this work. And so in November 2019, the Anne Arundel County Executive and myself as well identified racism as a public health issue, and that this was something that we were going to address. And we were one of the first jurisdictions in the nation to make this declaration. We were the first in Maryland. And we pledged to open an Office of Health Equity and Racial Justice and funded it to launch in July 2020. And that synchronizes with our budgeting schedule, which is why there's that delay. But we did make the conscious decision to not just say health equity, but to also identify racial justice, because while there are a range of health disparities and equity issues, I think the reality is that racial inequities constitute one of the, if not the biggest, but certainly also the longest standing inequity that exists. And to not explicitly mention that is kind of just to be a little quiet about the thing and hope that everybody's kumbaya on the health equity piece. And they are mostly, but I think this puts it really to the forefront to say that, you know, we have to pay special attention to this particular facet of it as well. And then COVID happened. And I don't need to explain to this group that COVID essentially rewrote all of our social priorities, and we poured all our effort into COVID. It doesn't mean that we didn't do other things, and I'll talk about that later, but you know, we really did have to pivot very hard to COVID, and look at what health equity means in the context of COVID, and particularly in the context of race. And so I include this slide, and I'm happy to share these slides later if you'd like, but it really is about making sure that everybody has a fair and just opportunity to be as healthy as possible. And it requires removing obstacles to health, such as poverty, discrimination, and their consequences. And racism is one of those obstacles that needs to be removed. And so there's four things that we're really focusing on when we're talking about health equity and racial justice. And the first is data disaggregation. Dr. Jones mentioned that as well. You know, it's really hard to actually make traction if you're not talking about and specifically identifying data that explains what is happening, right? And while I tend to nerd out and talk a little bit more about quantitative data, qualitative data is also a part of this. They go hand in hand. But data disaggregation, breaking down data by geography, race, ethnicity, gender, helps us to better understand who health disparities are affecting, right? Whenever you see a top line number, this percentage of people had diabetes in this county, the important question to ask is, who's getting it more? Where is it happening? And then you get to ask the questions of why and then how to deal with it. But if you think that everybody's getting it at exactly the same rate at exactly the same time, you're not going to make progress on that issue. But when you ask these questions and you commit to sharing what that data looks like, it really puts it out there. It makes it incontrovertible. And there are people who will, you know, deny it or try to poke at it or whatever. But it's really hard for people to turn away from it. And it is the core part that allows us to then pivot to action. And so that action involves a couple of things: community investment, so engaging with communities, but also funding communities to do this work. And I'm going to talk about that a little bit of length. Changing systems, and then long-term funding. I think that it's important to understand that as I talked about our Office of Health Equity and Racial Justice, you know, our health department had an Office of Minority Health in the 2000s. I believe it was the latter half of the 2000s, but it was grant funded. And the grant funding went away, and so did the office for nearly a decade, right? And so core to kind of what we were thinking about was, how do we ensure the sustainability of this office so that it can do the work that it needs to do? And that's why, that's why we wanted to get this, and we did get this into our base budget for municipalities, counties. Our base budget is the funding that we get every year. It allows us to do the operations that we do. And once it's in our budget, you know, we get to spend it how we need to. Obviously, we're trying to hew to, you know, what we put in the budget, but there's flexibility in there. But more importantly, it's not optional. It takes an act, once again, of a county council or a legislature to explicitly take it out. Can that happen? Yes. Is that likely to happen? No. And so as we were doing this work, obviously COVID reared its head from, from our health department perspective. It was on our radar pretty much in January. So we do this declaration, we're thinking in November 2019 about all the different things that we can do. And then COVID comes in January, and it's pretty evident to us that the question is not if we're going to get hit, but when, and can we get, our pieces together in time. So as we're looking at COVID, we focused on equity quite heavily. We focused on how do we do community pop-up testing. So taking our testing, and remember, there was only testing available in the beginning. We had testing out in community in partnership with community organizations within a month of it landing in Anne Arundel County. How are we making sure that we are pre-registering people, but getting it out to people who wouldn't normally have access to it? I think we're all familiar with the phenomenon of people with good computer access being able to sign up for things pretty quickly, right? And that's not evenly sorted out. We looked at our vaccine equity plan. How are we doing rental and housing assistance? And actually, at the health department, we provided stopgap rental and housing assistance to people who couldn't qualify for programs. And this was largely directed towards minority communities. But I want to focus on one of those items, our community health ambassador program. And this was an effort to expand our outreach and provide vaccine information and education in underrepresented and minority communities. And I've included the logos of the eight partners who we have continuing with this program. And key to this was that we didn't want to go do the outreach. We see ourselves at the health department as having technical knowledge. What we see our community partners as having is the knowledge of the communities that they serve. And our question was, how do we put those two together? So often, we try to staff up ourselves, but we don't have that in-depth knowledge of communities, and we certainly can't do it at the countywide level. Not with 590,000 people, we can't hire people who intimately understand, the neighborhoods, whether it's Brooklyn or Severn or Lothian or all the other communities that I can name. So we wanted to fund organizations that were rooted in community, have them hire people known to their communities, and additionally build capacity in those organizations by making sure that the money is going to those organizations. And we looked at census tract data. We said, who's getting vaccinated and who's not? If you have a high vaccination rate, you don't need this community health ambassador program. If you have a low vaccination rate, you do, right? And that was really our main driver of this. And so we had programs scattered throughout the county. We had different organizations keyed to different zip codes based on whether they had membership and programming in those areas. And what we saw, the results of this effort was that communities where the health ambassadors were present and actively performing their outreach saw a 20% increase in their COVID vaccination rates from 46 to 66%. At the same time, non-targeted zip codes only had a 12% increase, because there was a secular rise in vaccination rates over this time, but we saw that our efforts had an incremental effect above and beyond that. And that these newly vaccinated residents were often from minority communities with low vaccination rates. And so over this time, we saw that while the countywide vaccination rates increased by about 17%, we saw that for African Americans, it increased by 21%. For Hispanics, it increased by 29%. And it increased by those numbers because it was lagging prior to that. And that's the result of consciously investing in communities. And I think that the lesson that we've taken for that is very, very intentionally saying, how do we not wait until the rate is lower? How do we build this into whatever effort we're doing from the drop, right? That's really our goal. And I would love to say that we did that from the drop. We didn't. But our goal is to do better next time. And in light of this success, we were able to get this program funded into our annual budget. So we were initially using the ARPA dollars to be able to fund this program. That's great. We did not want it to go the way of every other grant funded program, was to die on the vine. We had built this, not only the success in terms of vaccination, but I think much more importantly, we had built an infrastructure of partners to be able to do this work who were excited to address these issues of health. And frankly, they address it in their work on a daily basis, maybe not as intentionally, but this allows us to do that. And so starting in July, just a couple of months ago, this is now in our base budget to be able to continue to fund this program. And we're expanding this to address mental health issues this year. So all of the community health ambassadors throughout these 8 programs are going to be trained on mental health first aid. Mental health awareness education is going to be a part of what they are doing through their outreach. And a key part of that is decreasing the stigma by talking about this. We have what was initially weekly health equity and racial justice meetings. We have them now monthly, and over what comes out is this issue of stigma, this issue of who is and isn't talking about this. And we hear in both the Black community and the Hispanic community and the Asian community that there's a stigma around talking about these issues, that there's not a lot of folks from these communities going into these professions. Obviously, most of the folks on this call are in that profession, but I think we know that there's an underrepresentation in this field. And so part of this is there's also a longer term benefit into this, is that talking about it allows us to not only address it in the now, but also really open the door to talking about this in the future, considering this as an occupation for somebody to go into, and for it to be, in 5, 10, 15 years to see much better, or maybe even parity in terms of representation in these professions, so that people can get treatment in their communities also. So looking more broadly at our timeline on health equity, I talked about us starting in March. In March to May of 2020, we were having our weekly health equity meetings, had member meetings with our Black and Hispanic communities. Our Health Equity and Racial Justice Office was established July 2020. That's its official date, because that's when its funding came through. And critically, that allowed us to really expand on this disaggregation of data. We have our community health ambassador program, which we noted. And going forward, really, our goal is to develop a health equity plan for the county. We would have had this in 2021 at the top of it, but we had a couple of years of COVID that really just didn't make that possible. And while I'm sharing a key program that we have, even just talking about this and talking about this repeatedly, I've seen the effects where others in the health department and in the community start to think about it more and start to think about, how do we address that? And that meaning disparities, racial disparities in the data that we see. And it really, it might seem like a small example, but I think it's an important example of, there was a concern in the southern part of our county, which is rural, around air and water pollution from a construction site that's occurring in a predominantly minority part of the community. And when you look at the health statistics in that part of the county, you can see that there's lower health attainment there, right? And so the question is this construction leading to air or water pollution? And so we did additional testing at the request of the community, and what we found is, there wasn't any additional water pollution in that area. We're still working on the air pollution piece to do the testing for it, and I think more importantly, we were able to sustain a dialogue with the community to say, you know what, it might not be the water that's causing it, and that's okay. But what is it that we can do to address the disparities that do exist, right? Let's not say, well, if it's not the water, then we're out. The real question is, why are these disparities there? And how do we continue this and probing this and working on this so that we can actually achieve parity in terms of our health outcomes? I have to brag a little bit because I have to. Our Office of Health Equity and Racial Justice was one of 2 awardees statewide for an innovation award But I think it's important to note that these are all the people that made it happen, right? Like I'm talking to you as a representative of the health department, but we don't do this alone, not even close. We do this with a whole range of county and community-based partners, all of whom are doing this work, you know, on their own oftentimes. And one of our core goals, like I said, is to make sure we can fund this work long term. So with that, I thank you, and I will turn it back over to Dr. Hutchins.
Okay, thank you both for those presentations. I think that definitely frames the conversation that we need to have. I think we've got a few more minutes. I will remind our viewers to place your questions in the chat, and I'll try to respond or get as many of them on the table as I can. I do want to make a few comments that I didn't make in the beginning, and I just simply wanted to underline maybe some things we heard either this morning or this afternoon. And one of those that I think is becoming clearer now, that some of those inequities that we're seeing are intentional. We have, courtesy of our current political environment, our current political atmosphere in the last few years, we have people who are openly saying, you know, we need less quote unquote minorities, we need less Black people. One of the things that we saw at COVID is that as quiet as it's kept, you know, some officials were making conscious decisions. You know, you got a certain number of hospital beds, and you got white people who need to get to beds, and you got Black people who need to get to beds. And guess what? In New York City, you started seeing a whole lot of Black people dying. And the issue became, why was that disproportionate? Well, it was disproportionate because people were making choices. We had the same thing in Maryland in reference to vaccinations. There was a serious discussion about who's going to get vaccinated. Where's the state going to send its doses? And fortunately, the numbers came out that Black people were being left out of that, courtesy of the Black Caucus and a number of other people. That got balanced. But the fact of the matter is that along the way, people were making decisions. Now, some of those were intentional, some of those were inadvertent. I think one of the things we picked up during the lunch discussion is that a lot of space decisions invariably wind up being race decisions. You know, we're going to put this in this district, and without any regard to the fact that that is a predominantly white district, that middle class people are more likely to be there than, say, poor Black people or poor Hispanic people. So I think part of it is understanding that some of the race disparity we're seeing is inadvertent. It's an after effect. But increasingly, we're beginning to see a lot of that is, in fact, intentional. And I wanted to put that out. I guess I'm going to leave it at that. I wanted to mention that back in the 70s, Samuel Yatt wrote a book called A Choice, and it was We Charge Genocide. And he actually talked about the fact that the Black community was being subject to genocide. And he defined genocide not only as intentional efforts to eliminate people, but the omission of other kinds of things that could happen. So when you look at a community where there's a food desert, knowing that people need healthy food to survive, and you don't provide food, you are committing genocide. You know, if I got a child who's hungry, knowing that children need to eat, and I don't feed the child, I'm not shooting a child in the head, but I know, in fact, that if I don't feed the child in due time, the child will die. And we're seeing that, I think, across the country and certainly in some parts of Maryland, where that omission and unawareness or pretended unawareness of certain consequences are creating some very harsh situations for us in terms of those disparities. Let me pull the chat and see what kind of questions we have. I know one that came up while Dr. Kale Narama, is that it? Close enough? I used to say that about Hudgens a whole lot, so I understand the pain. Somebody took issue with the use of the term minority. Have you encountered that as a controversy in terms of your work or in terms of your experience?
You know, I'm open to a different word. We haven't. It's actually a term that's been used by the communities that we work with, and I think that I'm always interested in hearing what an alternative might be. So if anybody who wrote that in has a different term.
I actually wanted to comment on that. So some of the terms have been in the chat too, so minoritized. So, but I think some people are using so structurally marginalized or, so things, so the structural piece, and the marginalization piece, or and I saw somebody just put in the chat BIPOC or Black, Indigenous, and other people of color, which I hate. That's just me, because if it should be Black people, Indigenous people, and other people of color if you're going to do that. But when people start saying BIPOC, like when they say DEI, then you're losing the meaning of the words. We need to always be saying these words that are important, if that's what we're talking about. I mean, anytime we turn anything into an acronym, then you're losing the punch of the meaning. Somebody has here historically underrepresented communities, but even the historically and underrepresented, so that's all good. But like, what happened to people? So I had a note that these assaults, as you said, Mr. Hudgens, are not, sometimes they're intentional, sometimes they're just historical injustices that are being perpetuated by present day contemporary structures without identifiable perpetrators. Sometimes they're through acts of omission as well as acts of commission. So it's all of that. But when you say minority in a country where majority rules right now, that's what some people think that's what democracy means. And that's not what democracy means. Democracy, you can have lots of different processes and have people involved in democracy without majority rules. But when you're in a country where people think that, then anytime you minoritize people or say minority, you are saying they're not as important, or we don't really have to care about them. We can trounce on their rights. So I had a lot of agreement. Yeah, people putting lots of great things in the chat now. Historically denied communities. Yeah. I like structurally disadvantaged and structurally advantaged. So for me, because I always want to talk about the duality between the disadvantage and the advantage, I like structurally disadvantaged or structurally advantaged.
I think
let me just quickly comment. It's also one of my peeves, and I won't get into the long discussion, but for anybody that's interested, Charles Willie, noted Black sociologist, passed a few years ago. He despised minorities well, and he talked about subdominance in terms of a dominant group having the most power and a group having less power. But I think in terms of health and the context we're talking about, I really think it's just a BS concept. And what happens is we have white people, and then we try to find categories to put everybody else in. And the reality is that there aren't those similarities. I think we have to recognize that there are cultural and other kinds of differences between people. Yeah, Black people and Hispanic people are not white, but they're not the same. And when we start talking about health issues, when we start talking about the disparities we deal with, there's specifics we deal with. Just like, and it's not in terms of disparity, but when we talk about Asians, I mean, there's a hell of a lot of differences between Japanese and Vietnamese and a variety of people. And I think sometimes we kind of act as though, well, these are just the et ceteras. We really need to deal with white people, what's going on with white people, and then there's the et ceteras, and we find some ways to categorize them. My preference is a little bit more intensive, it's a little bit more laboring, but I think we need to begin, particularly in terms of health, we need to begin separating out and talking about who we're talking about. Because I think when we don't do that, then we sort of just give it a pass. That's just my thought. Dr. K, I think you're going to say something.
So I think that there's also a facet of this that has to do with what communities want to talk about, right? I'll give you a really good example. We asked repeatedly when we're working, would you prefer the term Black or African American? And we asked the same of our Hispanic community work group for Hispanic, Latino, Latinx, and we got honestly, a lot of not caring, as long as we would address the problems that they were talking about. And so one of the things that we try to think about is what's the language of the folks that that we're working with? What is the language that they want? And we're definitely at the nexus of kind of the the forefront of this discussion of how to talk about identity, because a lot of the heavy lifting that minority, BIPOC, whatever, we're trying to say non-white in a really fancy way.
Mm-hmm.
At the end of the day, right?
Yeah,
But that's bluntly what we're trying to do.
it is. But I
But it
think that
doesn't
all of that,
capture what's happening, right? Non-white is just not white. It doesn't mean anything in terms of actually dealing with people at a human level.
but all of that is also not talking about racism.
Correct.
So they're two different things. So Mr. Hudgens, there's ethnicity, many ethnicities in all the so-called races. Absolutely. Race is this socially assigned thing. Somebody looks at you on the street and they put you in a race. They don't ask, how do you self-identify? They don't ask, where were you born? Where were your parents born? They don't ask, may I have a little bit of your blood because I have a genetic hypothesis. They see you, they classify you, right? And that's the substrate on which racism operates day to day. That's a thing that's really happening. Within each of these so-called racial groups, there are ethnicities, which have to do with language and history and culture and all of that. And within Black, there are many ethnicities. Within Asian, within Hispanic, which is also being racialized, within white, there are many ethnicities. That has its own separate, that's a separate thing. But when we see racial health disparities, that is because of racism. And so when we get all into what do we call it, let's talk about racism. Let's focus from the people and how we describe them and talk about how the systems are structured, differentially.
Let me just add another dimension to that if I can. And again, I want to stay with the health thing, and it gets to some of what you just mentioned. We know that race is a social construction. There have been a couple of it. I wish I could remember the names, but I know a couple of them are African American. But there have been a number of doctors in the last year or two who have begun talking about the effect of race assumptions in medicine. When doctors are operating as though being Black carries with it a certain set of physical characteristics that manifests itself in how they treat people. And one of the things they're finding is that doctors are much more influenced by their cultural backgrounds, their cultural assumptions, basically the prejudices they grew up with, as opposed to the actual biology. It's hard to say that a Black person with strep throat is somehow going to be different from a white person with strep throat. But in some instances, and I think we had a discussion this morning, particularly about Black women and obstetrics and maternal care, turns out they're ignored. There's been a tradition of Black people being more vulnerable to substance abuse, so therefore when they have pain, the amount of medication they get is less. I think there was a person over at Johns Hopkins did a study a few years ago that Black women diabetics are much more likely to be given medicine because the assumption is that they're poor and therefore they can't afford to change their diets, they can't do exercise. So what happens is this whole thing that we call race takes on a reality. And when we talk about it in the context of health, it becomes a deadly reality. Because when you look at me and you see a Black man, and therefore my high blood pressure means that you're going to prescribe a medication that's different from the one that you might prescribe to a white person, even though there's no science supporting that, it becomes problematic. Any thoughts on that line of thinking? Because I think that impacts healthcare. Public health tends to be a very broad, general topic because we're looking at communities, but ultimately those health decisions translated to what do we do for individuals who are suffering from various deficits, who are suffering from various diseases, who are actually in pain and have certain kinds of things that need to be treated. How do we deal with those individually? And I think part of that discussion has to do with changing our view of how we look at people medically.
There are different people taking different strategies. So one is the training strategy, so train the doctors to, but when you train people that has short-term impacts, now if you can keep training or whatever, but the kind of implicit bias training is important. It helps people understand that they do have biases, but that kind of training isn't long lasting. What you really need to do is change systems. So within the healthcare system, the healing arc is something that's there's a healing arc campaign about to be launched in Massachusetts. In the Brigham and Women's Hospital, Bram Wispelwey and Michelle Morris and others did research over 10 years. They saw that Black patients with heart failure were more likely to be on a general medical floor, where white patients with heart failure were likely to be on the cardiology floor, and it mattered what floor you were on in terms of your outcomes. Mm-hmm. So they documented that, and then they put in a solution in the hospital, which is in the tickler system. If in the emergency department, somebody's about to admit a Black or brown patient with heart failure to the medical floor, a thing comes up, an alert, and says, did you know that we in this hospital have been doing this bad thing? Do you really want to do that? Do you really want to admit them to the medical floor? Or wouldn't you rather really want to admit them to cardiology? And if they want to still do the medicine, they have to say a reason. The cardiology floor is full, or there are other reasons I want them on medicine, or write something else. But that little intervention is just a tickler, has had huge impacts. Now, when people found out about that, 25 neo-Nazis in the spring were out one Saturday in front of Brigham and Women's Hospital with big banners saying Brigham and Women's is killing white people, right? Killing white patients. It wasn't at all, and everybody's care was getting better. That's what we see is when we so-called center the margins, when we take care of those people who have the least, then everybody, if you change the system for them, everybody benefits. But anyway, so I think that individual strategies will have important starting points so people can get all in. Mm-hmm. But structural changes are what we really need.
Let me raise one other issue that tends to override this, and I'm surprised nobody asked about it, and that's the conflation of class with race. A lot of decisions that are really race decisions sort of get disguised as class, and once we say, well, it's because they're poor, because they don't have money, then it's okay. You know, we're going to put these people in this ward, or we're going to give them that treatment, as I say with the diabetics, because they don't have any money, or they don't have enough money. And at the end of the day, they kind of get confused. And I think one of the things that somebody said in the earlier panel, I think with infant mortality and maternal mortality, that when you start looking at Black women, class kind of disappears in terms of their vulnerability to the kinds of complications that take place in pregnancy. And in fact, that those vulnerabilities seem to be much higher among Black women than white women, regardless of the income status. So I guess I want to ask, you know, what do you think about that as one of the, I guess, the confusions involved in, or the difficulties involved with trying to deal with race, things that eventually manifest themselves as race, but people are comfortable once they can write it off as class to move on to something else. Dr.
K, do you want to go first?
Yeah, sure. So there have been a number of, across different conditions looking at multivariate analyses, right? Is what are the different factors that go into outcomes? And I think we've seen, I'm going to generalize here for a second, but that race is an independent factor aside from class, right? There is a class effect, but there's an economic class effect, but there's also a race effect. I think the infant mortality one, the maternal postpartum outcomes is certainly one that's gotten a lot of attention. But once again, this goes back to that issue of racism, right? It's not the race itself that is creating this determinant, it's the racism that is creating these outcomes. And I think that's why, talking about racism specifically, and to your point, Dr. Hudgens, like there is, I think, a burgeoning movement to try to disentangle some of these racial predictors that were, I think, meant well in terms of trying to do better care. But our confounders, a good example is using race in terms of identifying kidney dysfunction. It's been a pretty standard. I was taught that 20 years ago, that the way we calculated kidney dysfunction, you look at a certain biomarker in the urine, you look at their age, but then you also look at their race. And what that meant was that people who were African-American were less likely to be appropriately categorized, and they were typically categorized as having less kidney disease than was actually the case. And so for equivalent kidney functions on in-depth screening, right, in-depth testing, weren't getting access to medications or transplant lists at the same rate that they should have been. And so I think that there's also a vein here of trying to disentangle disentangle that racism and even well-meaning but ultimately unfounded efforts in the medical system to try to address this. And I, you know, my concern is that it discredits medicine as we try to do better. That's a reckoning that we're going to have to deal with, and that's on us to deal with it. But I do think that it is an important piece of that work going forward.
May I say two things before we close? Because that's
you're going to get the last word, so go ahead.
Well, I don't need the last word. You're going to have the last word, but I just want to say two things. So in this country, we have a very strong feeling that race is biology. I mean, there was even Bidil, a medicine that the Food and Drug Administration actually prescribed for Black patients. But I have to tell you, race is not biology. Now, because of racism, then we are, you know, I've described accelerated aging. Other people call it, you know, weathering hypothesis, you know, but we're tending to age more because of racism, right? But there's nothing genetically different. We've mapped the human genome. There's no basis in the human genome for racial subspecies. So, but there's a strong pull toward that. The other thing though, this class and race thing, it doesn't just so happen that people of color in this country are overrepresented in poverty, while white people in this country are overrepresented in wealth. That's not just a happenstance. And for each marginalized, stigmatized, oppressed group of people, there's been some initial historical injustice, the enslavement, kidnapping, enslavement, taking of the land, and your genocide, lots, and contemporary present day structural factors in the redlining and the like that are perpetuating those initial historical injustices. Those present day structures are part and parcel of structural racism or institutionalized racism. When you ask, are you talking about race or are you talking about class? Structural racism explains why we even see an association between race and class. So class should never be an explanation for racial differences. Structural racism is why we even see any association between race and class in this country. That's point one. The second point is, if we're about health equity, I would like to propose these three principles for achieving health equity, which probably tie everything that's been said in our session and hopefully today. The first is valuing all individuals and populations equally. The second is recognizing and rectifying historical injustices so that reparations is not a bad word. And the third is providing resources according to need, which you demonstrated, Dr. Kalyana Raman, when you were talking about how you used the vaccination rates to decide where you were going to invest in the community health ambassadors. If we do those three things, value all individuals and populations equally, but that doesn't mean you give everybody the same thing. You value your kids equally, but you don't give them all the same thing. You give them what they need, right? So valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. We could add 20 more things to that list, but you have to at least be doing those three things if you want to get to equity. And racism is a huge barrier to our getting to equity in this country. We must address that.
Okay, my last comment, I guess, and this is a whole nother can of worms that we won't have to time to deal with today. There's an interesting book by a doctor a couple of years ago called Dying of Whiteness. And he talked about the number of poor whites, the huge volume of poor whites that are dying for policies that are aimed to punish Black folk. In terms of Medicaid added in, the whole Affordable Care Act, a lot of health decisions, Kentucky and Tennessee are pushing back because they don't want certain things to happen for Black folk. But in the process, a lot of poor whites, and maybe not so poor whites, get swept up in it. So needless to say, we have covered a lot of ground. And I thank both of you for your contributions and your participation. Clearly, there's a lot of work to be done. And hopefully this symposium is the beginning of putting together other efforts, much more concrete efforts down the road, politically and otherwise, to make sure these things are addressed. It looks like, and I know this is out of character in terms of where we're going, but it looks like we're going to have a change in the political climate in this state in the next year or so. And hopefully that climate will have a situation that's more receptive to the kinds of things we're talking about. But it's our responsibility to make sure those things are on the table and not to just assume because there's a change in politics that these will automatically happen. And I have to say, a lot of things happened during the current administration because people were comfortable and, I should say, courageous enough to put things on the table that need to be on the table so that we can make the decisions that hopefully can prolong and create a better quality of life for more of the people, in this case, in Maryland and in the communities we're concerned about. Thank you all, and thank you for the opportunity.
Thank you all.
Thank you.
Thank all of you so very much. This is wow, what a remarkable, robust, and meaningful conversation. Dr. King proclaimed once, it's time to get the language right. Thank you all so much for commandeering your language to have this amazing discussion. And as Dr. Hudgens said, it is just the beginning. It needs to be, this discussion and the action that is inspired by it needs to really, really take place sooner, better than later. We're going to go into a 15-minute break. Afterwards, we will go into our second sessions for the day, our second set of sessions. So please be mindful of the time. We're going to start in exactly 15 minutes. Please enjoy this short period of rest, and we're going to come back and hear some more amazing discussions. Okay? Thank you. Just to solidify, we'll return promptly at 2:45. Thank you so much. Section. We're going into the second session, the second section of workshops. There will be in room 1, workshop entitled Anti-Racism in Action, Strategies for Equitable Practice. In room 2, I Can't Breathe, Understanding Cultural Trauma and Grief Experienced by African Americans. In room 3, Feminist Therapy, Research and Pedagogy, Principles for Centering Black Voices. In room 4, Combating Racial Battle Fatigue. Wow, Combating Racial Battle Fatigue through Healing Music for Black people. So those are the 4 workshops that we're going into. And again, just select from the breakout rooms. I trust that it will work efficiently. And I think we're quite ready to move forward. Let's go. We'll see you on the other side. There we go. Okay, I think I see Andrea there. I think we're back. I just left a great workshop, and I'm sure you all enjoyed yours as well. This has been just a remarkable, remarkable day of presentations and conversations that must go on, particularly in this political and psychological environment that we're dealing with right now. I just want to thank Andrea and Roxana and dear brother Richard Rowe for having invited me to be a part of this incredible day. And if you all call, I'm coming immediately, because these types of forums are so vital. I'm going to do a quick, David Miller asked me to spit something. So I'm going to do it real quick. And I think this will put a fine close on it. And then I'm going to turn it over to the lovely Andrea Brown. So this is from a piece that I wrote called Cotton Caskets. I'm only going to do the first verse. This is the story, because I think I'm going to do this first verse because I think you all outlined it in all that you presented today. This is the story, the truth, and the light of a nation, a people, and a perilous plight. It began at a time that seems all but forgotten, when Black bodies were trapped on killing fields of cotton. Vicious, vile, and vast plantations fertilized the roots of depraved fixations, giving rise to a culture and birth to a nation. Think about that. Thank you, Andrea. I'm going to turn it over to you now.
Thank you. Thank you so much. You can hear me good. Thank you so much. And thank you, Keith. I appreciate David requesting that. That was this whole notion around giving birth to a nation, but that'll be the next symposium. Sawubona. And for those of you unfamiliar with the term, it's a Zulu greeting, and it means I see you. But it's more than just being polite. It means I recognize your worth. You are important to me. I value you. And here at the Black Mental Health Alliance, we have added into that, I see you and I honor your humanity. And so thank you for the brilliant speakers and workshop leaders today. You were amazing. Everybody, I was trying to jump in and out, and I know some had music, so it was just powerful. And thank you for the warning about the triggers that could occur, because this is real life. This is serious that we deal with every day. A big thanks to our partner in the symposium, Hope Health Systems. Your support made this symposium a reality, and we could show up our authentic selves, uncut, straight, no chaser, and we were able to keep it then earlier and now keep it 100. And so it has been a day. And I could ask you the question, are you woke? But somebody asked that already. And it's been answered and a charge to it. In full transparency, this year's symposium theme, the powerful quote from James Baldwin, there's never time in the future in which we will work out our salvation. The challenge is in the moment is always now, was actually the theme from the canceled symposium last year. And as politics would have it, the title was changed from Racism and Mental Health to Race and Mental Health. The cover program resembled that of a kindergarten kumbaya collage. Workshop titles were changed, and the department for which we previously partnered was basically dismantled. And we were clear that we would not be associated with a farce. We stayed true and spoke truth to the perceived power. We did not apologize for staying woke and staying true to lifting the voice and the needs of the Black community. And so we did not participate in that symposium, and it was canceled. We are back and grateful to set the record straight about what lurks behind closed doors and open doors. I recently had the opportunity to read a brilliant literary work by James Baldwin. It's been out of print for a number of years, but I was able to get a hold of it. And it's absolutely brilliant, as is all of his work. And it's called Nothing Personal. It's a critique about American society at the height of the civil rights movement. Social isolation, race, politics, and police brutality is all woven in that. Sound familiar? Yeah. It's a page from a headline today. And while I have great respect for the literary works of Brother Baldwin, but in this moment for me, for you, and for us as a collective, it is personal. It is deeply personal. To be Black in America is dangerous, and to be Black and unhealthy in America is deadly. What we are witnessing is a direct consequence of years and years of carefully crafted anti-Black, anti-brown laws, policies, and messages designed to strategically silence Black people and other marginalized groups. That's personal. That's real personal. Our healing can no longer be put on hold. Our wellness is not up for a vote, and it's not an option. That, my friends, is personal. Don't be fooled. There is an attack on your Black mind, your Black brilliance, your wellness, your healing, our wealth, our land, and our being. The healing of Black people must be a priority, and it cannot be delayed like emancipation. It can't be delayed like emancipation. We don't need another book club discussing white fragility and guilt. We are moving against not only those forces which dehumanize us from the outside, but also against those oppressive values which we have been forced to take into ourselves. Dr. Jones shared earlier, we must move racism to action, dismantle racism, and take the door off the hinges. Now that's action. She is speaking our language. 400 plus years as an endangered species has taught us that if we intend to live and be well, we must learn how to change the game and get in it. One of the most basic Black survival skills is our ability to change, to metabolize our experience, good or ill, into something useful, lasting, and effective. And I say today, let's start by knowing and telling the truth. And the truth is, it is unnatural for Black people to fail. It is unnatural for us. It is unnatural. We have on the inside of us everything that we need to be successful. But wait for the book on that. We don't need another apology. What we need is a redistribution of resources on the local, state, and national level, and every Black community in these United States. Be great, America. We can support Black healing and liberation. Please, by all means, send your money to cities like Buffalo and Charleston, but send a crisis team of Black clinicians to help manage decades of being underserved and underlooked. Send it overlooked. Send in the truth. Don't wait for another Ferguson or Flint to cut short the lives of our children through water or bullet. Exchange the lie for the truth, and don't be afraid to tell the real story. Don't stand on the sidelines. I know you're tired. You can't be. This is not the moment to be weary. Get in the game. Create a Black ecosystem where we teach, train, and treat our communities. Take a day to heal from the lies that you've been told, and then take another day to heal from the lies that you've told yourself. Increase your commitment to social justice and social change. Be the modern day Ella Baker, Sojourner Truth, and the list goes on. There are several of you, Malcolm, where are you? And in the words of Mary McLeod Bethune, I'm gonna be quick here, I'm gonna finish up. She says, I am my mother's daughter, and the drums of Africa still beat in my heart. And I have changed that to read, we are the sons and daughters of our ancestors, and the drums of Africa still beat in our heart. The ancestors are waiting for us to take the stage. There's been an outline. We don't need another template of how to be great and what to do. We have it. This is our stage. This is our moment. I cannot thank you enough for your time, your talent, and your commitment to participate in a much, much larger call to action. Wait for it. You'll get a meeting from the family. There's gonna be a meeting of the family, of the heads of the family, so that we don't have to have this conversation again. We can stop pontificating and we can stop all the rhetoric, we will show up in full force. And so I leave you again with, I am my mother's daughter. You are the sons and daughters of our ancestors, and the drum of Africa still beat in your heart. This is your moment to show your voice. This is our moment. This is our stage. Thank you very much for showing up and participating. Thank you for all that you do every day. Thank you. I am Andrea Brown. In real life, I'm actually, I almost wasn't going to say it, I'm actually Harriet Tubman, and I'm calling you to participate with us. I'm calling you to be on the front lines. And just in case there's any doubt, I am Andrea Brown, and I approve this message. Thank you for joining us, and enjoy your day. You funny.
Germany, from Atlanta, Georgia to Barcelona, Spain. What's going on? From Detroit, Michigan to Vienna, Austria. What's going on? I often ask myself, what's going on? What's going? What's going on?
Natural born hustler, nigga stunting is my strong suit. Flexing with 100 cash, look at what these songs do. Gangsta and a baller, baby, I do what I want to. I be with some steppers, I don't care about what you gon' do. West it like the Warriors, all my niggas gon' shoot. He gon' have to take a loss, some my niggas gon' to. I know a bad bitch and I'm who she belong to. I just picked a Cuban off from wifey, bitch, these stones do. Dolce and Gabbana on my feet and these my favorite pair. Got a lot to lose, still can't be scared to take it there. I was in them slums, shit get dreadful like some Haitian hell. I come from that zoo, it's just cobras, pigs, and apes in there. 1300 block a bitch, I call my last cases there. Ain't no second chances in this shit, so we can't play it fair. Phone them line shit like a barber, Glock knock off his facial hair. Caught him lacking in his whip, they trying to find his face in there. Look how about he stay on go, bitch, all he know is green light. Let off shots with accuracy, show them what that beam like. Posted by the liquor store, was selling what the fiends like. Used to wake up in low income, now I live a dream. Natural born hustling, nigga stunting is my strong suit. Flexing with 100 cash, look at what these songs do. Gangsta and I'm ballin', baby, I do what I want to. I be with some steppers, I don't care about what you gon' do. Rushing like the Warriors, all my niggas gon' shoot. He gon' have to take a loss, some my niggas gon' to. I know a bad bitch and I'm who she belong to. I just picked a Cuban up from wifey, many stones. Grab me like a pharaoh with this money in my go-to. Keep a shooter if he try to rob me, that's the wrong tune. I hit Johnny Dang and Mr. Davis with the go-to. F and sing a song like it's the leader of a soul. Don't come out here like we friends, you know I don't know you. You know I got demons, allow me to show you. Lately I've been on the road, show after show. I know I'm making all the ops mad back. Been a while since I had to dial from a trap phone. See you later, alligator, quite a while, crocodile, we gone. Say our money stay long, pray for good aim when the devil try to go. Natural born hustle, nigga stunting is my strong suit. Flexing with 100 cash, look at what these songs do. Gangsta and a baller, baby, I do what I want to. I be with some steppers, I don't care about what you gon' do. Watch it like the Warriors, all my niggas gon' shoot. He gon' have to take a loss, some my niggas gon' to. I know a bad bitch and I'm